Hello, my name is Ellis Kokko. My pronouns are they, them, and I am a PhD student in social anthropology at the University of Edinburgh. Today, I will be talking about tracing the suffering transgender subject, mental health, identity, and futures in crisis. So, as we know today, the link between mental ill health and LGBT populations, and in particular transgender people, is a widely known fact, backed up by more than a decade of interdisciplinary research studies, public health agendas, and social justice campaigns, highlighting the impact of stigma and discrimination on mental health of trans people. Yet this idea that the cause of mental suffering is found in the society rather than the individual psyche, and that psychological effects should be a key focus when talking about marginalization, have not been part of mainstream public thinking until recently. While this narrative is arguably a positive shift away from an inherently pathologized subject, in this presentation, I propose that narratives of suffering leave little space for imagining livable trans futures. So, in this research, I'm combining historical archival research with multi-sited ethnographic fieldwork I'm currently undertaking in the UK to analyze and explore the role of suffering in the constitution of trans subjectivities and the unintended, often paradoxical consequences this has had on trans lives and politics. These questions originally were driven by my own experiences of coming to a transgender non-binary identity. Rather than through a sense of dysphoria, it occurred through an unexpected sense of joy the day I first walked into a trans-only community space. I was also suddenly faced with the assumption that transness is the defining source of suffering and marginalization in my life, leaving little space for the socio-economic factors that have shaped my life, or mental health issues not related to my gender identity directly. People who had previously illustrated a curious lack of empathy towards my depression and complex PTSD were suddenly concerned about my mental health as a trans person. I explore these questions through what I call the suffering transgender subject to refer to the historical centrality of different ontologies of suffering in constituting trans subjectivities and identities. In early biomedical accounts, trans suffering is a unique form of discomfort, a distress so debilitating as to require a drastic medical intervention. DSM-3 codified this diagnostic link between suffering and the transsexual desire, linking the two so that separating them became unimaginable. DSM-4 furthermore added emphasis on life problems such as isolation, depression, and suicidality. And as a result, transness became diagnosable through the struggles present in everyday life, and the binary between suffering pathology and non-suffering normality was introduced. In these biomedical narratives, suffering also had an important legitimizing effect. In 1979, the Hopkins Gender Identity Clinic stopped gender reassignment surgeries, citing research that there was no objective evidence of a positive impact on the patient's adjustment and social stability. In other words, the failure of the patients to demonstrate they were happier after. The notion of suffering here is linear and contained. The unhappy pre-operation trans subject becomes the happy post-operation subject, and her suffering is turned into a definite and intelligible entity that can be measured and cured. Emerging trans activism in fundamentally challenging medical understandings of trans subjectivities proposed a different ontology of trans suffering, moving away from subjects whose suffering resulted from their inherent pathology to a new kind of subject who is suffering due to oppression. Suffering thus remains central to making sense of trans lives in dominant activist accounts, constituting another way of making queer suffering intelligible, this time through ideas of morally legitimate victimhood. The transgender victim of violence is arguably the most recognizable form of the suffering transgender subject in the 90s and 2000s, appearing to the public through media and popular culture and as a topic of scholarly analysis. Although bringing a degree of public sympathy for trans rights, the unintended consequences of the anti-violence politics have been critically analyzed by many trans scholars afterwards, most recently by Laura Westbrook in their excellent book last year. By attaching affects such as suffering, pain, and dysphoria to transgender bodies, these bodies are produced in opposition to the figure of the happy same-sex couple, which is part of how the ontological boundary between gender identity and sexuality is reproduced, and which shapes the particular political position of transgender issues in society. The way in which these effects are not only linked, are also productive, but also productive of transgender bodies, can be understood through Sarah Ahmed's notion of affective economies, the productive capacity of feelings and emotions to become stuck to particular subjects and spaces, such as the transgender body. Suffering, therefore, does not only become a quality the transgender body has, but through which it becomes visible and intelligible to different audiences. It is against this varied history of transgender suffering that I try to very briefly recap here, that mental health emerges as a key framework for making sense of trans lives. What I find particularly interesting about the quotation from the World Health Organization here is not just the political significance of depathologization, but how after decades of opposition between trans activists and medical professionals, the language around the ICD-11 closely mirrors activist rhetoric and claims. Rather than viewing medical and activist discourses as opposite ends of a binary, I suggest they are more productively viewed as a part of the same entanglement of relations, co-producing the current suffering subject. Today, we therefore see an explosion of research into minority stress and the risk of suicide in transgender populations. At the same time, LGBT and trans organizations have begun to conduct their own surveys and seek to influence public opinion through the presentation of a series of worrying statistics on depression, anxiety, and suicidality. Discourses around mental health have thus become a powerful force that structures trans rights activism, policymaking, and funding decisions. If Brandon Tina was the face of the suffering subject 20 years ago, I suggest that today it might be better captured by the depressed subject. Narratives of suffering and crisis can be powerful ways to bring moral legitimacy to stigmatized groups. Yet, rather than neutral descriptions, they also shape the very identity categories in question by limiting the kind of subjects, effects, and futures that are recognizable. In my research, I seek to illustrate that the current narrative of suffering creates very uneven effects, and as becomes clear when we start looking at trans politics in the UK. One way to start analyzing the effects the suffering subject has circulating in political awareness is to analyze public discourses through the various public documents that exist that make trans subjects visible, including government action plans, medical guidelines, best practice guidelines for various professionals, government reports, and parliamentary sessions around gender identity. Here, a paradoxical image emerged. In the time range from 2008 to today, none of the official documents refers to transness as a psychiatric illness, but the vast majority of them refers to mental health and the psychological distress arising from discrimination and stigma. However, often such narratives of suffering were invoked to emphasize the need for medical professionals or the state to provide protection and guidance so that the very institutions become the solutions to their own violence. Second, while the link between discrimination and mental health issues functions as an important framing device in the publications I analyzed, the emphasis frequently placed on psychological distress effectively worked to shift focus away from structural factors causing it. Trans suffering was often linked to bullying or the emotional difficulty of the transition process itself, using words such as frustration, confusion, or discomfort. When the focus is on individual suffering, the solutions offered tended to therefore focus on either psychological help to the individual or training and awareness raising. Thirdly, claims for transgender equality emphasize the rhetoric of the most vulnerable citizens, helping whom is seen as desirable for the betterment of society as a whole. The government's action plans especially emphasize nationalist rhetoric of progress and modernity, while offering very few concrete promises for addressing inequalities. This is part of the work of stabilizing some subjects as victims and others as benefactors, as an example of the kind of binary logic the suffering subject produces. There are also exceptions. Most notably, the Transgender Equality Report by the Women and Equalities Committee in 2016 stands out by making concrete demands for structural changes. Yet the fact that it's all but unimaginable that this report would be published today is an indication of how the suffering transgender subject disrupts the kind of linear national narratives of progress that are usually linked to LGBT rights. With the current backlash and the failed GRA reform, it certainly feels like the suffering subject has failed to achieve public legitimacy. Here are just some of my favorite non-promises and strange justification for transgender equality that I found in the numerous documents and publications that I analyzed. Nowhere are these narratives quite as prevalent as in the case of the trans child or the gender non-conforming child that emerges as a particular articulation of the suffering trans subject. In December 2020, the High Court in the UK ruled it was unlikely that a child under the age of 16 could be competent to consent to puberty-blocking treatment, which has had drastic consequences for young people's access to trans healthcare in the country. The Bell versus Tavistock judgment enacts the same logic of the suffering narrative by painting an image of a vulnerable subject who needs to be protected. Paradoxically, the suffering and vulnerability of the trans child is also the image that many advocates have put forward for years in an attempt to invoke compassion. In the ruling, the presence of gender nonconformity itself becomes a sign of inherent vulnerability and a lack of agency. However, it is queerness that is seen as dangerous and that the child must be protected from. The court case also illustrates a clash between different ontologies of suffering. While there is a shared understanding of distress prevalent in the population in question, it is the issue of cause that becomes contested. How might one go about measuring psychological distress, its causes and alleviation? Here, the issue of proof seems markedly different from legal and medical perspectives. While clinicians that work with psychological distress assume their knowledge is always partial and might be later revised, the court demands a more absolute level of certainty and definitive proof of the cause, degree, and impact of the harm. It is the ultimate unintelligibility of suffering the court refuses to accommodate. Therefore, the judgment refers to the lack of proven benefits. Moreover, when the legitimacy of one's identity and rights is based on the subjective notion of suffering that does not bend itself to the kind of objective measurements required, I argue it also opens the door for competing claims of suffering and victimhood. In the political landscape where a certain kind of suffering and hurt is linked to moral purity and deservedness, which as we know are tightly connected to ideas of race, class, and gender, it is not difficult to make the kind of counterclaims as we have seen with the turf wars. In this terrain marked by competing victimhoods, rights aren't granted based on equality, but on who can invoke the most compassion and vulnerability. These narratives of suffering also shape the subjects, limiting the range of imaginable futures, effects, and identities. In my interviews with clinicians working with young people referred to gender identity clinics, they describe the difficulty of navigating the assumptions and expectations the gender identity clinic and the wider system it is part of creates. The system that requires certainty expects simple narratives and binaries. A person can neither be completely sure or confused. A person is suffering or not suffering. There is the right and the wrong kind of treatment. The cis clinician is objective and rational. The young trans person is subjective and emotional. The paradox is that while this narrative expects a performance of certain kind of distress from a young gender non-conforming client, it can also make it more difficult to express other types of suffering, as the wrong kind of anxiety might be taken as problematic ambivalence. In recognizing some forms of suffering, narratives of victimhood can thus make others invisible, hiding from the view subjects who don't fit into the neat binary such narratives demand. The trans clinician who might be subject to online abuse while working at the gender clinic, or the young client whose distress has more to do with other issues, such as racial oppression or an unrelated family trauma, and who is encouraged to view these as separate issues. Ultimately, attempts to make suffering intelligible reduce the complexity of lived experience and conceal power relations. The suffering gender non-conforming child is constructed through the idea of a universal mode of distress, creating the illusion of a homogeneous identity based on shared vulnerability. Constructed as separate from, rather than intertwined with material conditions. This narrative posits that all young trans people are equally vulnerable to mental health issues and that these are primarily linked to gender identity, which obscures other intersectional factors they might have in their lives. For Judith Butler, The key to a livable life is possibility, which is central to a notion of freedom. So the question is, how can we imagine trans possibilities and livable futures if trans lives are only intelligible through suffering? And how can we still recognize and acknowledge suffering without reducing affected communities and individuals to victims with no agency? And how can we make space for narratives of suffering that don't neatly fit into the binary assumptions? In my research, I've been impressed with how the people directly working with these issues navigate and inhabit these narratives in ways that can also challenge the kind of binaries the suffering subject can produce, and might thus create space for different formulations and futures. Any supposed stability of the suffering subject is thus like an optical illusion. Its different forms are constantly shifting, emerging through their interactions with different sites and actors. These are thus not static discourses, but the way these binaries are constructed and maintained in practice is always imperfect and full of tensions. It is precisely from these tensions that new knowledges and possibilities are emerging. The clinician's room in the gender identity clinic might also give rise to different kinds of possibilities and affects than the normative articulation of the suffering narrative I've been analyzing here. My point here, therefore, for us as activists, is not to stop talking about suffering and replace it with talks of trans joy and happiness, or to suggest that any specific effect will lead to a specific kind of result and a specific kind of politics. But I mean that we should make space for the full spectrum of affective experiences that make up our lives, so we can start imagining livable futures. Thank you.